Bismillahirrahmanirrahim. Dear colleagues, respected seniors, and my young doctor friends, Assalamu alaikum and a very warm welcome. Today we are going to discuss a condition that quietly sits at the intersection of two major epidemics of modern medicine: obesity and muscle loss. A condition that is frequently missed, poorly recognized, and yet profoundly affects functional capacity, metabolic health, quality of life, and even survival. We all diagnose obesity. We all talk about sarcopenia. But how often do we think about both together in the same patient? The overweight elderly patient who keeps falling, the diabetic patient with poor mobility despite normal BMI, the cirrhotic or cancer patient who looks bulky but is actually metabolically fragile. This hidden phenotype is what we call sarcopenic obesity, a paradox where excess fat masks severe muscle depletion. In today's lecture, we will move beyond definitions. We will understand the pathophysiology, diagnostic challenges, imaging and functional assessment, clinical consequences, and most importantly, how this entity should change the way we assess risk, plan nutrition, prescribe exercise, and manage chronic disease. My aim is not only to update your knowledge, but to sharpen your clinical eye so that you begin to see sarcopenic obesity in patients you may have been missing for years. Let's begin this important discussion. Bismillah ar-Rahman ar-Rahim. Sarcopenic obesity, a neglected aspect of dysmetabolism. Sarcopenic obesity when fate and frailty collide. Understanding the double burden of muscle loss and fat gain. The learning objectives of today's lectures are that by the end of this lecture, we should be able to define sarcopenic obesity, recognize its clinical impact and hidden risk, identify patients at risk in OPD, apply simple diagnostic approaches, implement evidence-based treatment protocols, and counsel patients on diet, exercise, medication, and follow-up. What is sarcopenic obesity? The definition overview. Sarcopenia means loss of skeletal muscle mass and strength, while obesity means excessive accumulation of body fat, especially visceral. So the sarcopenic obesity means coexistence of both conditions, sarcopenia and obesity. The clinical significance of sarcopenic obesity lies that it is an underrecognized condition in clinical practice, and it is associated with higher morbidity, disability, and mortality than either condition alone. Why does it matter? It is associated with increased risk of disability and falls, insulin resistance and type 2 diabetes, cardiovascular disease and NAFLD. Nowadays it is called MAFLD or MASLD. Poor surgical outcomes, increased mortality, and it is often missed because obesity hides muscle loss. Why is it neglected? Question is this. BMI alone misses the diagnosis of sarcopenic obesity. Patient looks well nourished. Physicians focus on diabetes, lipids, and blood pressure. Muscle loss is silent, gradual, and ignored. And there is no routine screening in clinics. The epidemiology of sarcopenic obesity, it is found in 8 to 23% in elderly. It means almost fourth or fifth elderly man or woman is suffering from sarcopenic obesity. It's higher in postmenopausal women, type 2 diabetes, MESL or MASH, and patients on long-term steroids, and those with sedentary lifestyle. Pathophysiology of sarcopenic obesity. The key mechanisms involved in pathophysiology of sarcopenic obesity are: there is a chronic inflammation, which is characterized by raised levels of IL-6, TNF-alpha, which leads to muscle catabolism. Then there is insulin resistance, which leads to decreased muscle protein synthesis. The third key mechanism is hormonal decline, characterized by decreased levels of testosterone, growth hormone, and insulin-like growth factor 1. Then there's mitochondrial dysfunction, which leads to energy deficit. Another key mechanism is physical inactivity, which leads to fat gain and at a higher speed. And then there is a low protein intake, which leads to malnutrition. So if we summarize all mechanisms, there is a vicious cycle. Obesity leads to generalized inflammation, which leads to muscle loss, and it leads to reduced mobility. As a result, there is further deposition of fat more sarcopenia, and further obesity. So this is a vicious cycle and it sets in, and with the passage of time, the severity of sarcopenic obesity is increasing. The muscle mass is gradually decreasing while the fat mass is gradually increasing. What are the clinical manifestations of sarcopenic obesity? There is central obesity with thin limbs, muscle weakness, slow walking speed, difficulty in climbing stairs, rising from chair, fatigue, imbalance, falls. There's reduced endurance, depression, and poor quality of life. What is the diagnostic criteria for sarcopenic obesity? There are two components. First is that the fat mass is increased, and this is determined by BMI, waist circumference, and visceral fat on ultrasound. And then there is low muscle mass or function, which is assessed by grip strength, gait speed, and DEXA or BIA. Let's understand the different components of this diagnostic criteria. First, the high fat mass is determined by the BMI. We know less than 18.5 BMI is underweight. 18.5 to 24.9 is normal weight, while more than 25 to 29.9 is class 1 obesity. 30 to 39.9 is class 2 obesity, and more than 40 is class 3 obesity. The second component for high fat mass is the waist circumference. We know less than 37 inches in male and less than 31.5 inches in women is normal. It's a normal circumference. More than 40 inches in male and more than 35.5 inches in female is considered to be in obesity. Remember, in South Asia, Chinese and Japanese descent, more than 35 inches in male and more than 31 inches in female is obesity. Then the visceral fat and ultrasound is the third criterion for, third component for the diagnostic criteria for high fat mass. Now coming to the low muscle mass function, the first component is the grip strength. The cutoff is for men less than 27 kg and for women less than 16 kg. If the grip strength is less than that, it means there is low muscle mass and low muscle function. And how it is calculated? By hand dynamometer, which is cheap and portable, and you can check in your clinics and in your OPD rooms. Then is the gait speed, speed of the gait. Less than 0.8 meter per second means high risk of sarcopenia. The timed up and go test, what is this? You ask the patient to stand, walk 3 meters and return. If it takes longer than 12 seconds, this is abnormal and it demonstrates low muscle mass. Then DEXA and BAI. The body composition, the gold standards are DEXA, dual energy X-ray absorptiometry scan, CT MRI of the thigh muscle, and what is practical in OPD, and these tools are BIA, that is bioelectrical impedance analysis, in calf circumference less than 31 centimeter means low muscle mass. The skeletal muscle index, the formula is muscle mass in kg or area into square centimeter divided by height in the square meter. And it is calculated by the DEXA or CT scans. When it is less than 7 kg per meter for men or less than 0.7 kg per meter square for women, this is diagnostic of sarcopenia. What are the clinical clues of sarcopenic obesity in OPD? If the waist circumference is more than 102 centimeter in men and more than 88 centimeter in women, ask yourself, does the patient walk slowly? When the patient was coming or entering the OPD room, whether he or she was walking slowly? Does patient need arms to stand from chair? Is there history that patient feels difficulty in climbing stairs? Or the patient is having fatigue out of proportion? Or there is a history of falls or near falls? If these are there, probably your patient is having sarcopenic obesity. There's SARC-F questionnaire in which there are different components like strength, assistance in walking, rise from a chair, climb stairs and falls. And then you ask, for strength, you ask how much difficulty do you have in lifting and carrying 10 pounds? And the patient says none, you give 0. If the patient says some, you give 1. If the patient says alert or unable, you give 2. Then for assistance in walking, you ask how much difficulty do you have walking across a room? When there's no difficulty, you give 0. When there's some difficulty, you give 1. And there's alert, use aids or unable, you give 2. Similarly, you ask for the rising a chair, climb stairs, and falls. All these questionnaires, they are available online. Then there's another criteria, the WGSOP2 criteria, and you means you find the cases, you apply this, and if it is negative, there is no sarcopenia, rescreen letter. If sarcopenia is found, you assess how much is the muscle strength, and when there is sarcopenia probable, you confirm by this, and then when it is confirmed, you assess the severity. So both these criteria, these are available online, and you can go through these two and understand how to apply these in your practice, or especially in the research scenarios. So I'll share with you a couple of scenarios. Clinical scenario number 1, 58-year-old woman, BMI 32, type 2 diabetes, hypertension, and muscle. That woman is having all these 3 comorbid conditions. She cannot climb stairs without rest, and she walks slowly, and her grip strength is low. The diagnosis: sarcopenic obesity. Clinical scenario number 2, 65-year-old man with BMI 27 but having fatty liver, looks normal. Frequent falls, the patient is giving history of frequent falls, slow gait, and his calf circumference is 29 centimeter. So the diagnosis: possible sarcopenic obesity, normal weight but high fat, low muscle. So, what should be the goals of the management of a patient with sarcopenic obesity? First goal should be, or it is, reduce the fat. Second goal is to increase the muscle mass. And the third goal is to improve the function. So your management should be having all these three goals. The lifestyle interventions, these are the main cornerstone therapy of these sarcopenic obesity. Exercise, pivotal role. Resistance training, 2 to 3 sessions per week, these are the cornerstone. And the exercise should comprise aerobic plus strength combination for best outcomes. Diet is very important. Ensure daily intake of protein of 1.2 to 1.5 gram per kg per day, and this protein should be of high quality source. Adequate vitamin D, omega-3 fatty acids, these are very, very important. Similarly, caloric restriction only with resistance exercise, because you have to take care of the obesity as well, but at the same time, you need to improve the muscle mass. Then behavior, this is again very important. Reduce sedentary time. Sleep and stress management are very, very important. Exercise, just like a drug, should be prescribed. How? Resistance training, it's the core therapy. You prescribe that it should be done thrice a week. Every session should last for 45 minutes. And the target should be to improve the thigh muscles, gluteus, arms, and core muscles. And examples of these are sit to stand, doing stair climbing, TheraBand exercise, leg press, and squats. Then protein prescription. Protein intake, as I said before, it should be minimal 1.2 to 1.5 gram per kg per day, and it should be spread across 3 meals: breakfast, lunch, and dinner. And the sources of the protein should be eggs, fish, chicken, lentils, and dairy. Similarly, what about the pharmacological therapies for sarcopenic obesity? Mostly these are supportive, correct vitamin D deficiency in these patients, manage comorbidities, that is diabetes, hypothyroidism if it's there. Similarly, the drugs under study, these are myostatin inhibitors, selective androgen receptor modulators, SARMs, growth hormone secretagogues, and GLP-1 agonists, dual benefit on fat and muscle. They improve fat loss and preserve lean mass. The management of sarcopenic obesity needs multidisciplinary care involving physician, dietitian, physiotherapist, and endocrinologist. All four are required. What about prevention and screening of sarcopenic obesity? Who to screen? Elderly men with obesity, diabetes, and sedentary lifestyle. Postmenopausal women, those on long-term steroids, are those with chronic disease like diabetes, hypertension. What should be the preventive tips? Combine resistance exercise with any weight loss plan. Monitor muscle mass during calorie restriction. When to intervene early? This is a very important question. Weight loss in obese older adults must include muscle preserving strategies. These are very, very important. What should be the weight loss strategy for these patients? It should be slow and structured. The target should be 0.5 kg per week. Avoid rapid diets. Use calorie deficient diet with high protein meals and resistance training. The drugs may consider in selected cases, and these are GLP-1 analogs, liraglutide, semaglutide, metformin, vitamin D replacement, and testosterone if there is hypogonadism. Avoid long-term steroids in such patients and overly restrictive diets. Special population, we should not forget, these are the postmenopausal women because there is rapid changes in hormones, there's increased visceral fat, and accelerated muscle loss. Counseling is essential. Follow-up protocol must be ensured every 3 months. You should check the weight, waist circumference, and gait speed, and grip strength. Similarly, strength exercises compliance must be checked every 3 months. And diet adherence is also very, very important. What should be the prevention strategy for sarcopenic obesity? Start from age 40, the exercises and the diet control and the lifestyle changes, daily walk, twice weekly resistance training, and adequate protein. This should be started from the age 40 along with vitamin D supplementation. And we should avoid prolonged sitting. So the key takeaways from today's discussions are sarcopenic obesity is the hidden malnutrition inside obesity. Screen, diagnose early and treat both muscle and fat components. Resistance exercise plus adequate protein is the cornerstone therapy. And treat muscle, not just fat. Prevention is easier than reversal. So remember, dear colleagues, obesity hides what frailty reveals. Look beyond the fat to see the muscle. Do not just reduce weight, build strength. The goal is not a thin, weak patient. The goal is a strong, functional patient. Thank you very much for being with me in today's discussion. Inshallah, see you in the next vlog on another topic. Till then, take care. Khuda Hafiz.